Hi, Part 4, Chapter 42, Diseases of the GI Tract. Just thank you for Elsevier and for McGantz's Pathophysiology text. Hepatic encephalopathy, a complex neurological syndrome characterized by impaired behavioral, cognitive, and motor function. Clinical manifestations of personality changes, confusion, irritability, lethargy, sleep disturbance, flapping, tremor. Sometimes it's just the first initial phase of confusion and a personality change, and then you might notice that if you pay attention carefully, that their sclera might be a little icteric. Treatment: correct fluid and electrolyte imbalance, withdraw depressant drugs metabolized by the liver, restrict dietary protein, hypertonic saline mannitol hypothermia if necessary, elimination of intestinal bacteria like neomycin or lactulose. The depressant drugs are, because the liver can't metabolize them out, the patient will be more somnolent and more depressed. Jaundice is icteric, with yellow or greenish pigmentation in the skin or in the sclera. You don't really notice it until the bilirubin gets greater than 2 to 3, sometimes even usually higher than that. Causes of extrahepatic obstruction of biofilm, with a blockage of the outflow of bile backing up the liver, intrahepatic obstruction, hepatocellular disease, cirrhosis, and prehepatic obstruction, excessive production of bilirubin from hemolysis. It sometimes occurs in cancer patients and also with other red blood cell diseases, such as polycythemia vera, when the cells start to die more rapidly. The pathophysiology, the hepatobiliary mechanism, intrahepatic, extrahepatic, and hemolytic, and it explains the conjugation. Clinical manifestation: dark urine, clay-colored stools, yellow discoloration, possibly the sclera, and then progressing to the skin. You have to wonder, why is the sclera first and then the skin of the face first and then the rest of the body? It really has to do with high blood flow. The face and head have the highest blood flow because of the brain, and the associated skin and other organs of the head get increased blood flow. So therefore they turn yellow first. You can see this is the yellowation that is because it's sclera first and then skin. Skin xanthomas, cholesterol deposits, and then they get pruritus, anorexia, malaise. Treatment: collect jaundice. Jaundice is only a sign of the underlying disorder. Hepatorenal syndrome is a renal failure. This demonstrated oliguria, hypotension, peripheral vasodilatation, resulting in advanced liver phase of the disease, usually associated with chronic alcoholic cirrhosis. Management: fluid, and then possible liver transplant, and using adrenergic agonists and Alterations. Severe impairment and necrosis of liver cells without pre-existing liver cirrhosis. Leading causes: acute liver failure, and acetaminophen overdose. So pathophysiology past becomes edematous, patchy areas of necrosis, and hepatic necrosis is irreversible. Clinical manifestations of anorexia, vomiting, abdominal pain, progressive jaundice. The various treatments: lowering blood ammonia levels, what you always do first, and then consider possible antiviral therapy for hepatitis, and reversing the acetaminophen poisoning with N-acetylsalicylate. Autoimmune hepatitis is rare, chronic, progressive autoimmune inflammatory liver disease. Clinical manifestations: no symptoms, jaundice. Treatment with immunosuppressive drugs, corticosteroids. Relapse rates is common with treatment with hepatitis A. Can be found in feces and bile, etc. Infectious individual. It's usually transmitted by fecal-oral route. Risks of overcrowded, unsanitary conditions, food and water contamination, prevention, hand washing, administration of vaccines is really important. Hepatitis B is a parentally and sexually transmitted disease. Maternal transmission occurs in the mother. Hep B vaccine prevents the transmission to develop Hep B. Hep B immunoglobulin provides post-exposure prophylaxis against Hep B. So if you're exposed, you can get Hep B immunoglobulin and try to prevent the development of the hepatitis. Hep C is responsible for most causes of post-transfusion hepatitis. Is implicated in infection related to IV drugs. Co-infection with Hep B is common. Approximately 80% with hepatitis C develop chronic, but no vaccine is available. Administer antivirals. I often talk to you about often screening of patients for veteran status because a very large number of veterans, Vietnam era veterans, have Hep C and Hep B. Hep D and E, D dependent on B for antigen replication. Hep E is a fecal oral transmission, contaminated water, uncooked meat, most common in Asian and African countries. Vaccine China, but not in other countries. Prodromal phases. Periicteric begins 2 weeks after exposure, ends with the appearance of jaundice. Icteric phase begins in 1 or 2 weeks, and then phase. Cirrhosis is the irreversible inflammatory fibrotic disease that disrupts liver function, even liver structure. Most common cause is alcohol abuse and viruses. Hepatic function from nodular fibrotic tissue synthesis decreases. Biliary channels become obstructed because of hypertension, and you can get portal hypertension. Alcohol liver disease is oxidation of alcohol causing damage to the hepatocytes. Steatohepatitis is alcoholic fatty liver. It's the mildest form. It's reversible if drinking stopped. Alcohol hepatitis is steatohepatitis. It's characterized by inflammation during the necrosis of hepatocytes. And alcoholic cirrhosis is the actual fibrotic changes. So alcohol liver disease impairs the hepatocyte's ability to oxidize fatty acids. Clinical manifestations include nausea, anorexia, fever, abdominal pain, and jaundice. Cessation of alcohol, rest, nutritious diet, corticosteroids, antioxidants, slows the fibrosis. Management of complications is ascites and other infections, bleeding, and encephalopathy. This is the kind of a flow chart of how liver inflammation, pain, fever, anorexia, they develop the signs of increased androgens, estrogens, and then eventually leading to all the what we previously just talked about: hepatic failure, encephalopathy, coma, and death. Non-alcoholic fatty liver disease is infiltrated from hepatocytes from fat. Primary triglycerides occur. And biliary bile cannula cirrhosis begins in ducts with the ducts. Just as a note from cirrhosis of the liver is that a friend of mine's son-in-law was having lots of problems in life, became a heavy drinker, drank a lot of alcohol for many years, and recently died at the age of 49 from liver failure from alcoholic cirrhosis of the liver, which we just got done talking about. Some event causes fibrotic changes. So, and this fellow worked on Wall Street and was a very successful guy, not successful socially, but successful financially. And you can see that that alcohol is a drug if used in excess, like all drugs. Primary sclerosing cholangitis is a chronic inflammatory fibrotic disease of the hepatic bile ducts that leads to secondary biliary cirrhosis. So a person has alcoholic liver disease. What is the sequence of developing disease? It's prehepatic intrahepatic. No, it's not. And the steatosis, fibrosis. That's the answer. Overflow peripheral vascular. No, incubation. That's how you get disease. So it's steatosis, steatohepatitis, and then fibrosis. Cholecystitis is gallbladder gallstone formation. Cholesterol stone formation of bile and supersaturated cholesterol. It's caused by enzyme defects, decrease of bile fatty acids, and decrease of absorption, gallbladder smooth muscle, hypomotility, genetic predisposition, any combination of all the above. But one of the things we used to say, which I'm not sure is always completely true, is we can fair fat and 40, particularly in women, were high risk for thinking about cholecystitis, particularly if they present with left upper quadrant pain. So pigmented stones or black stones formed in the gallbladder associated with chronic liver disease, hemolytic disease composed of calcium bilirubinate. Brown stones are associated with bacterial infections, bile ducts, formation of stones composed of calcium, and soaps. Clinical manifestations: epigastric and right hypochondral pain. Sometimes it's towards more to the left, but basically it's midline or epigastric pain. Intolerance of fatty food, biliary colic, lodging of stones in cysts and common duct, jaundice and stone and bile duct, abdominal tenderness and fever, and cholecystitis. Treatment: laparoscopic cholecystectomy is preferred, transluminal endoscopy, surgical repair, and large stones lithotripsy. Alternative treatment is use drugs to dissolve. This is a remarkable picture of a beautiful gallbladder with all these stones in it, and you can see that this took a long time to happen. Cholecystitis is just the inflammation of the gallbladder. Acute and chronic clinical manifestations: fever, leukocytosis. Treatment: pain control, replacement of fluids, fasting, antibiotic administration, and laparoscopic cholecystectomy. Pancreatitis is an inflammation of the pancreas associated with several clinical disorders and intakes caused by injury of the pancreatic cells and ducts. These cells, the enzymes, cause autodigestion of the pancreatic tissue, causing injury to blood vessels and organs. There's acute resolves spontaneously. Clinical manifestations is epigastric pain, mid-abdominal pain, nausea, vomiting, fever, leukocytosis, elevation of serum lipase. Treatment: narcotics, NSAIDs, and acetaminophen, nasogastric suction of IV fluid. Many times it's associated with alcohol. And this is what acute severe pancreatitis looks like in a normal pancreas in B. This is the hemorrhagic spots, hypertrophied and damaged pancreas. All these can be leaking enzymes that can self-digest themselves. Chronic pancreatitis, repeated exacerbation of acute pancreatitis, can lead to chronic pancreatitis. It destroys the sinus cells, islet cells of one hand, and the pancreas is destroyed, replaced by fibrous tissue. Chronic alcohol abuse and smoking are the most common cause. So this is somebody who has acute pancreatitis many times and then develops into this chronic phase. Treatment: oral lipase, insulin, corticosteroids, cessation of alcohol use, analgesics. And if they're young enough, they can actually have a pancreatectomy, partial. Cancer of the esophagus is a chronic inflammation, dysplasia because of gastroesophageal reflux, exposure to irritants. Clinical manifestations of chest pain and dysphagia. Eventually they get severe epigastric pain, sometimes confused like cardiac pain. Treatment is removal of primary lesion and local nodes. Cancer of the stomach, environmental respiratory infection with Helicobacter that carries the Ka gene product, and cytotoxin associated antigen A, 80% of the causes. Dietary factors: high salt intake, food additives, nitrates, and low intake of fruit, vegetables. Also associated with chronic atrophic gastritis, lifestyle, alcohol consumption, cigarette smoking. These are where the cancers of the stomach occur. In the pylorus, the greater curve. This is the greater curve, the lesser curve, greater curve. Antrum. Cancer begins in the glands of the stomach mucosa. Symptoms do not usually occur until the tumor is metastasized. Treatment is surgical removal. The incidence of gastric cancer has dramatically decreased in the United States, but is ever increasing in the third world and undeveloped countries of the world, and it is the sixth leading cause of death in the world. In the United States, it's the eighth leading cause of death in the United States, but it is the third or second cause of cancer deaths in developing countries. Carcinoma in the small intestine is rare. It's usually an adenocarcinoma. You probably won't see it. It may be associated with Crohn's disease and adenomatous polyps. Cancer of the rectum is the third most common cause of cancer deaths in the United States, and develops from the same adenomatous polyps. And so the colon, the shape of the polyp characteristics. This is where they are located in the descending colon, only 5%. In the sigmoid rectomoid, it's 45% of all cancers are seen. If you add this one, it's 50% of all cancers are up at the descending colon, and the remaining 50% are in the transverse colon and ascending colon. So colonoscopy only catches about 40% of the disease, whereas many more can be caught right here in the left side. Treatment, surgery, possible colostomy, radiation, adjuvant chemotherapy. Rectal cancers up to 16 centimeters from the anal verge to the anus. Tumors spread transmurally through the vagina in women and prostate men. Cancer of the liver, the factors in infectious hepatitis A, B, C, and D. And it can be caused by chronic alcohol, liver disease, long duration heavy smoking, hepatic iron overload. Hepatocellular carcinoma is developed with hepatocytes. It's usually associated with hepatitis B, and it's one of the most common cancers in developing countries because of the incidence of hepatitis. And this is what cirrhosis looks like. A is micronodular and B is macronodular. You can see the destruction of the liver. And cancer of the gallbladder is quite rare, but it does occur, and usually treatment. Heavy cigarette smoking, alcohol abuse, history of pancreatic cancer, diabetes mellitus, chronic pancreatitis, obesity, and non-type O blood. And this is a map of pain